We start with our case presentation. May I call upon the presenter, Dr. Julia?
Okay, thank you. Is my voice audible?
Yes, doctor, you are audible.
Okay.
So we'll go through the
Thank you.
case that
Today's
you
case
want to present
presentation.
today, and we'll have the discussion after the session.
Okay, thank you.
Okay, please start.
Okay, today's case presentation is about a 24-year-old female patient with a diagnosis of left breast cancer, angiosarcoma with a bone and lung metastasis. And her initial presentation was with a worsening of shortness of breath of 7 days duration, and she was having associated cough, severe pain over the left leg, as well as loss of appetite. Next slide, please. On the history of current illness, she was initially diagnosed with a left breast sarcoma 2 years back, presenting with a left breast swelling of 3 months duration. She got admitted and mastectomy, modified radical mastectomy was done, and eventual discharge with a short appointment. Later on, she was started on chemotherapy, which she took for up to 6 cycles of second-line chemotherapy, and she disappeared for 2 months, where she was trying holy water as a part of treatment, but with no improvement. She was taking morphine 30 milligram every 6 hours and bisacodil 5 milligram pure daily at that time. On her current presentation, she was having severe 8 out of 10 continuous dull pain over the left thigh of 1 week's duration, which got worsened with the movement and relieved with the OTC medications which she was using in addition to morphine. And she was also having pruritic chest pain, which was in moderate severity, 5 out of 10, which has a quality of intermittent stabbing quality. And associated with that, she was having a worsening of shortness of breath, cough, and loss of appetite with a weight loss. Next slide. Upon physical examination, she was on respiratory distress. Her respiratory rate was 32 breaths per minute, and she was tachycardic with a pulse rate of 120 beats per minute. And her BP was in normal range, 118 by 82, and her temperature was 98.2 degrees Fahrenheit. And her oxygen saturation on atmospheric air was 82%. On systemic examination or respiratory system, she was having dullness and decreased air entry over the left one side of posterior lung field. On musculoskeletal system, she was having tenderness of a proximal femur, and there was visible muscle atrophy on both upper and lower extremity. On other system, there was no pertinent positive finding on other system. Next slide, please. And she was, for this presentation, she was investigated with CBC. Her WBC was 4.1 thousand, neutrophil of about 60%, and lymphocyte of 24%. And her hemoglobin was 10.5 gram per deciliter, platelet was 320,000. Her serum creatinine was 1.02, and her serum potassium 3.5 millimole per liter, and sodium was 134 millimole per liter. Her calcium was 8.3 milligram per deciliter. On chest CT finding was a left pleural based lung mass, hilar lymphadenopathy, and a left pleural effusion with the likely cause of lung metastasis. Then, after the patient was thoroughly evaluated, immediately she was simultaneously started on intranasal oxygen. She was put on 5 liters per minute of intranasal oxygen, and she was started morphine. The morphine was switched. Initially, she was taking 30 milligram PO every 6 hours. That morphine was switched to IV dose, which is 4 milligram IV every 4 hours, and bisocodyl 5 milligram PO per day, and she was put on maintenance fluid and other supportive care. And eventually, she started to maintain oxygen saturation with the 5 liters per minute of intranasal oxygen, but she continues to complain leg pain as well as chest pain. Initially, as previously mentioned, she has taken first-line chemotherapy as well as second-line chemotherapy for about around 6 cycles, and she was booked for third-line chemotherapy before her current presentation. Next slide, please. On psychosocial aspect, she's a 24-year-old unmarried woman living in her parents' home. She has 3 siblings, one of whom is a medical officer who is currently supporting her and the whole family. She's a devout Orthodox Christian who uses to go to church regularly. She feels sad that she cannot go to church as she used to. She has a low mood, she was tired, and she feels helpless. She's not much communicative about her illness and being talked to. Her brother, who is taking care of her financially, feels frustrated and he's uncertain whether to continue the chemotherapy which was booked for her on a previous visit. And he keeps asking, her pain and the condition are not improving. What do you think is the best we can do to improve this? He keeps asking such questions. Next slide, please. Current medications, she's on intranasal oxygen, 5 liters per minute, morphine 4 milligram every 4 hours, and bisocodyl 5 milligram PO daily, and maintenance fluid, supportive care. She was already booked for third-line chemotherapy. Next slide, please. Currently, the main concern is leg pain, so severe leg pain, 8 out of 10. And she was also having concerns like physical symptoms, shortness of breath, cough, loss of appetite. She feels depressed, and there is a concern of the family. Specifically, her brother feels frustrated that the current medical interventions as well as other alternatives they seek it is not improving her condition. These are the 4 main concerns from this patient's presentation. To summarize, this 24-year-old unmarried woman having a left breast angiosarcoma with a bone and lung metastasis, currently presented with a complaint of shortness of breath and left thigh pain of 1 week's duration. She has associated cough, bloated chest pain, and loss of appetite. She has taken 6 cycles of second-line chemotherapy, and she disappeared for 2 months from the follow-up. She feels depressed, and her family is bothered that chemotherapy and other interventions are not bringing relief to her suffering. Next slide, please. The discussion points for this case presentation is role of opioid in management of cancer pain. As you have heard, the patient was put on morphine 4 milligram every 4 hours, but still she feels she's experiencing pain. Upon reassessment, the pain score was 7 out of 10 after she was put on 4 milligram every 4 hours. So in such scenario, how do you adjust her morphine dose to control her physical symptoms? One of the points we discussed is this. The other is, in case if her pain is not controlled with a tolerated dose of morphine, what alternative opioid can we give for this specific patient? Is the second point. We can discuss. I think I've seen there is a question about whether she was having breakthrough pain, requiring breakthrough dose. Yeah, she was having breakthrough pain, of around 2 times per day over 24 hours, for which she was being given 4 milligram of IV morphine. And the second point of discussion is managing psychosocial issues. As you know, and under the managing psychosocial issues, the points I want to be discussed is, do the psychosocial problems relate to her pain? Do psychosocial problems her feeling of low mood and feeling of hopelessness? Does it make it difficult for us to manage her pain using only morphine? And if so, how are we going to manage this, address these psychosocial problems? These are the points for discussion. If you have additional questions as well as suggestions, you are welcome to forward it. Thank you for listening attentively.
Thank you, Dr. Jalay. So we'll have a detailed discussion after the session. But before that, let's have a small discussion among ourselves. Okay, so you have seen this patient is in severe pain. Let's identify what are the types. Let us identify the total pain for her. So concerning a physical issues, what are the physical issues you are facing? You have gone through the history. What do you think are the physical issues you are facing? Pain, breathlessness, loss of appetite, cough, loss of appetite, depression. Okay, let's go for physical issues. Cough, loss of appetite. Okay. Okay. Now these are the physical symptoms that you are seeing. So what do you think we can expect from such a person in suffering? Which are the physical symptoms? Anything else you want to add? What about sleeplessness? If she's in pain, there is breathlessness, sleeplessness could be there. What about any other physical issues to add, Dr. Jalay? We are just discussing about the physical issues she might be having.
Yeah, already she's on laxative, she's on bisacodyl, and she was not having constipation at her presentation. As already mentioned, she can have sleep disturbance because she was having pain. Her pain was not relieved with the current medication.
Okay, then let's go for the another part, the psychological issues that she might be facing. Depression, anxiety. Worry for the future, anxiety, hopelessness. Okay, worry for the future. Guilt that she might be a burden. Feeling of hopelessness, unsure if pain will end. Feeling of guilt for family members, feeling of the doom. Yes, fear. You're having such great answers. Mood disorders. Okay, spiritual issues. Okay, spiritual issues. Why despite religious something? Okay. Yes, definitely the spiritual issues can come up. Fear of non-subsiding pain. What about the social issues? Economic issues definitely can come up. Okay. Financial burden, isolation. Yes. Feeling of being a burden, dependence. No friends. All right. Yes. Future instability. Yes. Dependence on us. Yes, that's a great thing. Very big fear that everyone will be having, depending on others, even for activities of daily life. Like she might have the need might arise when progresses, when born, especially when born with progresses, she might be need progresses could worsen, and she might need help for her activities in daily life. She's very young and must be isolated from her peers. Yes. When her friends might be going to college or school for studying, she would have to, her life would be restricted to her room. She's an unmarried woman, making a lot of chance to meet someone. Yes, that's another issue about her future life. Okay, Dr. Julie, you want to add anything more to the psychosocial issues that your patient might have had? What do you think of the answers, reading all the answers?
Okay, actually, most of the participants have mentioned possible psychosocial problems she might be having, since she was not.
That's a great answer. Sorry to interfere. Dr. Divya Narayana has pointed out two major issues: sexual issues, loss of self-image. Yes, that's very like underexplored in a normal history, but very important about them. Okay. Continue. Please continue, Dr. Julian.
Pardon?
Please continue. You were speaking.
Okay. Thank you. Okay, no problem. Actually, most of the participants have mentioned, since she was not more communicative, it was not easy to bring out most of her concerns. Possibly, she might be having social problems like feeling of isolation, uncertainty about her future life. Like, as you know, she's a married woman, and she, as like anyone else, she wants to have. She have the feeling of she wants to get married. She wants to have a family like any other one of us would wish, and possibly she might have such kind of feeling, uncertainty about the future regarding her marriage, as well as uncertainty about even the current treatment. She's not sure whether the further improvement might come or not. Those uncertainties are there, as well as possibly she can have a lot of issues related to spiritual issues, because, as I mentioned, she feels that she was not having a routine visit to the church as she used to. So it was not easy to dig that in detail, but possibly she might have spiritual issues as well.
Thank you, Dr. Julie. That was a good case presentation. Now we have identified the issues. Now, after the session, we will continue with this discussion about how we can manage. So we have our faculty here. May I invite the faculty for the day, Dr. Rutula. She's an assistant professor in palliative medicine, Department of Critical Medicine, Bharati Hospital, Pune. She has done an MD in palliative medicine from Tata Hospital, Mumbai, and is currently working in Bharati Hospital and Research Center, Pune. She's interested in research in palliative medicine, especially non-oncology and pediatric population, with a keen interest in making palliative care accessible to those population and improving quality of life. May I heartily welcome Dr. Rutula for the session.
Hi, thank you for waiting, and I'm sorry I joined in late. So without any further delay, I'll just start presenting my slides. Just give me 1 minute. So I'm assuming that you've had the previous session on pain, like pain 1 was done. So can you briefly tell me what all you've covered in that? Anyone? You can type it in the chat as well.
And NSAIDs were covered, adjuvants were covered.
Okay, so can you briefly
Paracetamol,
define? Okay,
paracetamol
can
was
you
covered.
just define
So basically, it was non-opioids.
non-opioids? Okay, but can you tell me what? So in briefly about what exactly is pain and what? How do you assess it, or what are the things that you look for in assessment of pain? Can you see my slides?
Yeah. So it was like
Yeah.
a PQRST.
Okay, PQRST. Excellent. Anything else? Was someone said? Okay. Okay. Okay, so it was defined, I mean, it was divided into nociceptive or neuropathic and nociplastic concept that has come up now. So that line of management for each would differ. Like for nociceptive, let's just keep it simple to nociceptive and neuropathic. So nociceptive is what we are learning now. Neuropathic have their own medicines and different classification and different pain assessment scale as well. So nociplastic concept is a bit different, and it's just coming up. So not a lot. It's still not very well defined into management part of it. So we'll keep that aside for now. So coming to management of pain. So basically, we'll just briefly recap on what principles of pain management is, the step ladder of WHO, and we'll go from there. So I'm sure you've covered this previously, but basic principles is that we need to go by the clock, by the ladder, by which class of drug that we need to use, and attention to further details, any associated symptom, right? So what it means is that we need to choose the analgesic drug properly. We need to choose an appropriate drug, appropriate dose for that drug, said drug. The timing of the administration of the drug plus the route by which we need to give it should be scheduled and administered properly. The aim is to control the baseline pain and manage the breakthrough pain as well. So we need something for the breakthrough pain or the exacerbation of pain, intermittent pain as well. And daily or regular titrating of the drug should be done according to the half-life or how it is for that particular drug. We need to do that properly. And we also simultaneously need to look for the associated side effects and or even anticipated side effects and manage them appropriately. So we all know this, what the ladder is. So mild pain, mild to moderate, and moderate to severe. So for mild pain, we generally use non-opiates like NSAID or paracetamol, plus or minus adjuvants. And from step 2 onwards, we use ladder. For step 2, they had specified the use of weak opioids. Weak opioids would be your codeine, tramadol, in some cases tapentadol, but tapentadol is considered as a strong opioid by some of the authors and as a weak opioid by some of the authors. So it depends, plus or minus adjuvants. And for step 3, it was strong opioids like morphine, fentanyl, or buprenorphine. Now, according to the recent changes in the WHO guidelines, and according to the NICE guidelines and ESMO guidelines for chronic cancer pain management, what they have suggested and what research has shown is that lower doses of strong opioids are preferred over weak opioids. So that means that instead of using codeine and tramadol, it is opioids that are available with us. So those are the latest guidelines. But again, according to the availability, according to individual patients, these can differ. So we are mainly focusing on step 2 and step 3. So this is the general list of all opioids, weak plus strong. So we have morphine, hydroxycodone, buprenorphine, pentazethidine, nalbuphine, buterol, naloxone and naltrexone come into the antagonist part. So basically, that is the list that we have. What is available with us here in India is morphine, codeine, fentanyl, methadone, and buprenorphine. Pethidine is available, but not preferred anymore. So the other ones are the ones that you will be using. And for buprenorphine particularly, I'm coming to this point, it is a partial agonist antagonist at mu receptor, plus it has an activity on the ORL receptors as well. But at lower doses, it is a pure agonist. So pure agonist of mu receptors at a dose less than 32 milligrams. So what we are using for pain management comes into the range of pure mu agonist and not as a partial agonist antagonist. So coming to the commonest used opioids in our setup. So tramadol, this is generally, it can be given via all the routes. So per oral, IM, or IV, starting 25 to 50 milligrams of tramadol. In combination doses that like Ultracet or Ultramax or Narcodol, the combination 5. So this is a weak opioid. It has mu agonist activity plus an SSRI activity. So it has its effect on neuropathic pain as well. That's why, especially when the patient is suffering from a mixed type of pain, nociceptive plus neuropathic, tramadol seems to work better than, let's say, morphine or the other congeners. It is because of the SSRI activity of the drug. The main emetogenic. So generally, it is preceded by either metoclopramide or in some combination tablets, even domperidone is present. So you need to be cautious for that. Any other precautions that you can think of particularly? Oh, I'm so sorry. Can you hear me now?
It's okay, audible.
Which part did you miss, Dr. Chaitra? Hello? I'll just switch off my video if that's, hopefully that should just stop it. Yeah, can you hear me now?
Yes, ma'am.
Yes, ma'am.
Okay. Okay. Where did I lose you? Like, from what part did I lose you? Do you want me to repeat
Tramadol.
anything?
Is
The whole thing?
tramadol.
The whole thing was not audible. The whole thing was not audible, sir?
Well, it was audible, but a little disturbance in between.
Okay. 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 So I'll just briefly Tramadol is a weak opioid with actions on mu receptors. It's a pure mu agonist, plus has its effect on SSRI. It's SSRI. It has an activity via SSRI as well. So it is more helpful in neuropathic and nociceptive mixed type of pain. So sometimes it may show even more efficacy in mixed type of pain compared to morphine. So highly effective in that area. Generally, you start off with a dose of 25 to 50 milligrams, depending on the patient. 0.5 with paracetamol and plus or minus domperidone. The major side effect of tramadol, especially when given intramuscular or intravenous, is that it is highly emetogenic. So generally, before giving tramadol, we give metoclopramide or domperidone, and we give a very slow push. So especially for intravenous injections, the 50 milligrams is diluted in 100 cc, even 100 is diluted in 100 cc's basically, and given over a period of around 40 minutes. So can you think of any other side effects with tramadol? Someone's session. Okay, so SSRI function is basically, yes, so it is predisposes the patient to serotonergic syndrome, especially if it is given with other serotonergic drugs. So patient has
Ma'am, your voice is breaking up in
polypharmacy.
between.
Excellent. Someone also said seizure. So that is a, sorry?
Your voice is breaking up in between.
I think it is an internet problem.
Okay, now we are
Can you hear me now?
Can continue.
Oh, yeah, okay. So you need to be cautious while using it with other serotonergic drugs. So interaction should always be checked for those medicines. Seizure threshold, it lowers the seizure threshold with the dose of approximately 400 milligrams, 300 to 400 milligrams. So you need to be cautious if the patient already has a seizure disorder. Then in cancer patients, if the patient has any space occupying lesion in the brain, then you should avoid giving tramadol, because I have seen seizure after tramadol infusion. So you need to be very careful about seizures. So you should avoid it in any case where seizure potential is present. Then respiratory depression, not so much. I personally haven't seen respiratory depression with tramadol, though I have seen it with tapentadol. So there, the risk of respiratory depression is always there. So you should be very, very cautious, especially in patients renal function. So you should avoid tramadol, morphine, codeine, tapentadol in patients with deranged renal function, especially if the creat clearance is less than 50. It should be titrated according to the excretion of the medicine. So SOS basis, and then get the baseline dose of the drug. Constipation is present in all of the opioids, including fentanyl, though the frequency or the nature of constipation might differ, but it is present even with fentanyl. Then vomiting is, yes, correct. Drowsiness for the initial 2-3 days, maybe you will be a bit drowsy, but generally with tramadol, it's not as severe. Delirium that is present with in the patient. So if it is along with, let's say, electrolyte imbalance or with are predisposing the patient for delirium, then maybe delirium might occur with with tramadol as well. Hallucinations. So basically all the side effects that are that can be like a blanket blanket side effects of particularly you need to just focus on the emetogenesis of and the serotonergic effects. Okay, suicidal ideation, not so much, unless the patient is actually addicted to taking tramadol and cannot function without taking tramadol. I'm sorry. Your voice wasn't clear. Can you repeat it? Okay. Suicidal ideation, unless
Ma'am, we couldn't hear you, ma'am.
or the person is addicted to for. I'm sorry. My internet is... Am I audible now?
Yes, ma'am.
Yes.
Okay. Is this better? Then I
Ma'am?
will not use that much of it going on around. So there's a lot of disturbances from outside.
Ma'am,
Now it's audible, ma'am.
I have a question, ma'am.
Okay. Yeah, please go ahead.
As you said that tramadol has a, do you need to do a kidney function test the patients on tramadol?
Yes, I generally do. So before starting,
Ma'am, the voice
any
is
opioids,
We are losing you again.
We are not getting your voice.
properly, ma'am.
hello, can you hear me? Can you just give me 1 minute? Just 1 minute.
Okay.
Okay, ma'am. Okay, ma'am. Please.
Now,
Yes, ma'am.
okay. Hello, can you? Am I audible?
Now
Hello.
you're audible.
Okay, okay. So coming back to your question, I usually do a liver function and kidney function before starting any opioids. If the renal functions are renal or liver functions are highly deranged, then I would prefer giving fentanyl and both renal and liver safe. So basically avoid any of all these patients is via liver and kidney. So to have proper both of them. So yes, I would repeat a renal function test. If it is not recent enough, then I would repeat it. If it's in, let's say, in the range of 10-15 days, then I would not repeat it. Function and liver function before starting it. Any other questions, sir?
Ma'am, I have a doubt.
Please go ahead.
Ma'am, for example, if it's an emergency condition and
Right.
they are having severe pain and we don't have the blood investigations in the near future, is it better to give tramadol or can we go to other drugs? Ma'am?
If you have, like, if the available is there, then I would prefer fentanyl. You can give a low dose of fentanyl instead of doing tramadol.
Sure, ma'am. Thank you so much.
Yeah. Then coming to, why is it? Another weak opioid, that is your codeine. Codeine is to morphine and then has its so coming to morphine, we have available is your instant release tablets in 20 milligrams, 30 milligrams. You have your controlled release tablets in same dosage, like 20 and 30. So, or sustained release tablets that are available for 12 hours. So you need to be every 12 hours. We don't have the 12-hour formulation, and we have injectable morphine available with us. So we do not have the oral suspension formulation that is available in other continents. It's not available in India. So the oral, while starting morphine in general, it should be understood, or rather it should be estimated how much the dose of given. If naive patient, opioid naive in the sense that has not had any opioid for pain before, or maybe once or twice, not on regular opioids, then you should start. I generally started at around 2.5 milligrams, divided over 2.5 milligrams every 8 hours or maybe 6 hours, not more than that, and then titrate it up as and when needed. But having said that, it should not be limited to just 2.5 milligrams thrice a day or 4 times a day. They should SOS dosages they require for the patient, idea of how much dose is required by the patient. So the SOS dosages can be given every 1 hour, because the half-life of morphine is 6 hours, right? It has to be every 4 to 6 hours, depending on the patient. Look at the onset of action of morphine. Oral morphine is 5 to 60 minutes. So you need to wait for at least 1 after giving 1 dose to give another if the pain has not subsided, right? So you can repeat those SOS doses every 1 hour till pain control. So what happens is that, and you tell them to write down how much they are tablets of that. Ask them to maintain a diary or a notebook. What happens is get to know.
Sorry to interrupt, ma'am, but your voice is breaking intermittently.
I am so sorry. The internet is not very good at this place. Can you hear me now? I'm actually sitting.
It comes in between clear, but it goes in
We
between.
lost, it breaks up in between. Now it's okay.
Okay. Okay. So, where did I lose you? If I can just ask, where did I lose you?
Basically, in between it goes, so it is difficult to concentrate because in between we miss some words and again it comes.
Right. Okay. Audible now?
Yeah,
Yes,
you are
ma'am.
audible, but in audible, AU was missed, and we heard the double.
Okay. Okay. Is
Not
Ma'am,
clear.
Hello?
hello, ma'am.
Hello?
Ma'am, could you send the slide to us so we can try from
Yeah,
it,
sure.
so that we can just.
Yeah. Yeah, I'll just send it. Just give me a minute. Can I send it on WhatsApp? Will that work?
Yeah, sure.
Mm.
Ma'am, have you sent the presentation?
Yeah, it's just getting uploaded. Just a minute. Just check if you've received it.
Not yet, ma'am.
Yeah. Can I try with the mail as well?
Yeah, sure,
Please,
ma'am.
please. Ma'am, were you able to send that?
I think doctor has gone offline.
Yeah, I think she's got disconnected.
We got it, madam. We will
Yeah.
play from our end.
Did you get it?
Yes, ma'am, we will upload it right now.
Yeah. Is it better now? Like I changed the.
Audio is clear now, ma'am. We'll see.
Okay. Just to I'm audible, right? You can hear me.
Yes, ma'am.
Okay. So just to quickly tell you about morphine. So what happens is that you start off low and you titrate it up, right? So the half-life is a half-life of morphine is around 4 to 6 hours. Varies from patient to patient. Sometimes it might extend up to 8 hours as well. So the dosing of morphine needs to be in that range. So it needs to be either from 4 hours to 6 hours. Again, as I said, it varies from patient to patient. So when you say you start low, you can start off with just 2.5 milligrams of tablet morphine, either on an SOS basis, like whenever there is a surge of pain or the pain just starts increasing, then the patient can take in the tablet of morphine. And or it can be like you give a round the clock dosing of generally, let's say 2.5 milligrams thrice a day, that is 8 hourly, or 6 hourly, that is 4 times a day. Meanwhile, don't be afraid to give in boluses or SOS dosage of 2.5 milligrams. So let's say the patient is on 2.5 milligrams thrice a day and but you've started the patient, you've just started the patient on this dosage, but the pain is not getting controlled. You can ask them to take the repeat of 2.5 milligrams after 1 hour. Now, why after 1 hour? Is because it needs that much time to act or have its full effect. So after getting, taking it orally, getting it absorbed through your stomach and
Ma'am, we lost you again, ma'am.
can you hear me now?
Ma'am,
Yes, ma'am.
Yeah. Okay.
ma'am,
Yeah, please go ahead.
uh, as you have said, for breakthrough pain, we need to start dose with 2.5 milligram.
Not for breakthrough pain. I am talking about an opioid naive patient. I am starting the patient on morphine directly.
Right.
So at that time, I start the starting dose is not 10 milligrams because it will be too high a dose for an opioid naive patient, and he might not tolerate that much. So I start off with a low dose of 2.5 milligrams because that is the amount you can break the tablet. It's already a very tablet, so you cannot break more than that. If you're giving injectable, I would just give 1 milligram. You understand?
Okay.
So basically starting off with a low dose. Yeah.
Okay.
So you can either give it SOS, that is, 2.5 milligram as and when needed by the patient, with a gap of at least 1 hour between the two medications because it needs that much time to start acting. Or you can start patient on 2.5 milligrams round the clock, that is either TDS or QID, and ask them to take SOS doses whenever required if the pain is not getting relieved or he's having surges in between. The only thing that needs to be done is to keep an account of how many 2.5 milligrams have gone throughout the day. So in 24 hours, how many have gone? So that is his baseline requirement of morphine. That's what we get within 24 hours. He requires, let's say, we asked him to take 4 times a day, 2.5 milligrams, but he's taken, let's say he's taken 12 times a day, right? So how much he requires is 2.5 into 12. So that much should be divided equally throughout the day. That is how we titrate the dose of morphine or the required dose of opioids. Is that clear or is it still confusing?
Ma'am, the last point, can you repeat again?
Okay, so let's say you've asked the patient to take 2.5 milligrams 4 times a day. Okay, and I've asked him specifically to give extra doses as and when required. Okay, but the patient, instead of requiring just 4, he took extra pills, which are, let's say he takes 12. He takes 12 extra pills in between with one hour ke gap mein. He has to take, and after 12 pills, he could sleep well at night. So total mein, he took 12 plus 4. That is 16 pills he took throughout the day. Okay, you're not counting the baseline dose that you advised. You're counting baseline dose plus the extra tablets that you took. Is that clear till now? Is that, or is it still confusing?
Ma'am,
That's clear.
is it possible to ask patient to take 12 tablets in a day, especially in our Indian patients? Is it safe?
It's 1/4 tablet. You're not taking the whole tablet. 2.5 milligrams.
I understand, but is it safe to ask our those who are not very much literate, and is it safe to allow them to take?
It's the amount of morphine that the patient is requiring, right? You cannot underdose a patient and let him suffer when you can actually make him comfortable, right? And if you calculate it that way, it comes up to, I think, 40 milligrams of morphine, which is still a pretty low dose throughout the day.
Yeah, I understand,
It's
but
not that high dose.
yeah, but the patient is taking it for first time. So are there
So you
any chance of respiratory depression after taking 40 milligrams?
Not with 40 milligrams. It's very, again, as I said, it's not very common to get respiratory depression with these low dosage unless the patient is predisposed to having opioid toxicity. So the risk of opioid toxicity would be if it is a deranged renal function or liver function or both. So in that case, you would avoid morphine altogether and would prefer fentanyl. So fentanyl is usually in a patch formulation if you don't want to give injectable. So that is the
yeah. Good evening, ma'am. Am I audible? I had a question.
Yes, please.
Am I audible? Yes,
You're
ma'am.
Yes.
So, ma'am, you said we will calculate over 24 hours how much milligrams of morphine is that the patient is requiring.
Yeah.
So, for the first 24 hours, the patient required 40. So, probably on the following day, is it safe to tell the patient to take one whole tablet 4 times a day?
And for
is that what we mean?
Yes. So what would happen is that then you ask them to take the whole tablet 4 times a day, plus SOS tablets as when required. Again, so again, you tell them that you take SOS tablets as and when required. So if in case he has a need, so 1 or 2 breakthrough dosages is accepted. If it's going beyond that, then you again up titrate the baseline dose.
Right.
According to the need of the patient. So you calculate.
Thank you, ma'am.
Yeah.
Thank you, ma'am. Thank you.
Yeah. Okay. So this double dose at bedtime is generally given for when you're giving Q4 hourly dosages. So at night time, you cannot get up in the middle of the night to take the medicine. So you can just take double the dose at the time when you go off to sleep, right? The calculation of breakthrough dosage is generally 1/6 to 1/10 of the whole 24-hour dose. So in case when you're, as you said, he's taking the same example, if the patient is requiring 40 milligrams in 24 hours, then the breakthrough dose would be approximately 4 milligrams. That's difficult to calculate. So you can basically take half the tablet of morphine as an SOS dose. So you need to calculate the breakthrough doses according to the total morphine required throughout the day. Morphine is highly constipating in general. So a regular laxative regime should be advised alongside morphine whenever you prescribe it. Even if it's a very low dose, you should prescribe a regular laxative. Antiemetics are generally required only for the initial 2 or 3 days. After that, they can be stopped. And if the patient has already been on some form of opioids before, he might not even require that antiemetic for the first 2 days as well. Any questions regarding anything so far?
Ma'am,
Yes, please.
ma'am,
Yes.
in your slide, you have said it 1.5 to double dose at that time. What do you mean to say that? 1.5 to double dose at that
2 times the dose. So as I said, if you're giving, let's say 10 milligrams every 4 hourly, and you schedule it accordingly, one of the dose comes in the middle of the night, let's say around 2 o'clock or 3 o'clock in the night. So you're not going to get up at 2 o'clock or 3 o'clock, because that is equally disturbing to the patient. So the nighttime dose should be double it. So you cover the whole night instead of getting up in the middle of the night. Is that clear? So you schedule
Yes.
it.
But we started the dose.
Yeah.
But we started the dose with 2.5 milligram 6 hourly.
Okay.
Am I correct?
No,
And
yeah. Okay. So in that
you say
case,
that 2.5 milligram 6 hourly or 2.5 milligram 8 hourly.
yeah, but the nighttime dose can be doubled, because nighttime becomes a longer duration. It does not come out to 8 hours. You're getting me? So if you take let's say,
I'm getting confused.
so if you take 6 hourly also, let's just stick to 6 hourly. It will the dosing would be 6-12, 6-12, right? 6 in the morning, 12 in the afternoon, 6 in the evening, 12 at night. Okay. So to get over asking the patient to get up at 12 o'clock in the morning, right? The nighttime dose, the night 12, midnight. You can change the schedule to, let's say, postpone the 6 o'clock in the evening to, let's say, around 8:30 in the night, and take double the dose. So you take the 6 o'clock wala dose also and 12 o'clock wala dose also. So that is 10 and 10, 20 milligrams at that time. Is that clear?
Yeah. Ma'am, and shouldn't
Sorry?
Shouldn't morphine be given?
Started the dose with
Starting the dose at 2.5.
Yes, we started the dose at 2.5. So 2.5 into 6 hourly, it comes to around around 10 milligram.
Right.
And in the meantime,
you're giving 10 milligrams. You give 2.5 at 6 o'clock in the morning. You give 2.5 at 12 o'clock in the afternoon. You give 5 milligrams at, let's say, 8:30 in the night. So that is 10 milligrams. You're not changing the overall dose of the medicine. You're just changing the scheduling of the dose.
And meanwhile, if they are still pain persists, you said that you go for a 1/6 to 1/10 of the dose of the 24-hour dose. Do you mean that also?
Sorry?
For breakthrough pain?
Again, it will be one. So in general, if you're giving oral tablets, the maximum low that you can go is 2.5, because below that you cannot calculate. 2.5 के नीचे अगर उसका भी आधा किया, you will not know how much the dose is. Right. So in case when you're giving it, let's say 6 hourly, and you require extra dosage, just give 2.5 extra.
Okay, now I get it.
Yeah. Yeah.
Now I get it. Yes. Because we started the calculating based on the 10 milligram dose.
Yeah,
which
no,
then
no.
you said the lowest
It's a higher dose, let's say 20 or 30, then you can calculate it via that.
Yeah, because we should start with a low and then go high itself. That is what is in Pallium.
Yes.
Thank you, ma'am.
So can we just take all these questions a bit later after the session? Otherwise, we'll not finish the session itself. Will that work?
Okay, done.
Yeah. Okay, great. Next slide, please. Yeah. So for parenteral morphine, again, the oral to parenteral conversion is 1/3 the dose. So if you're giving 30 milligrams per 24 hours orally, then the dose of injectable IV morphine would be just 10 milligrams in 24 hours, right? So generally diluted in saline, normal saline, or it can be given in dextrose as well. Breakthrough dose remains the same, 1/6 to 1/10 of the whole 24-hour dose. It can be given as a continuous subcutaneous infusion or continuous IV infusion. Again, you need to titrate it up or titrate it down according to the effect of the drug on the patient. It can be mixed with midazolam and metoclopramide. Midazolam is generally mixed with when you're planning for palliative sedation, but generally for pain management per se, we would give it just as a separate dose, right? So depending if you're giving continuous infusion, intravenous continuous infusion of morphine, then maybe it's a good idea to give it either through syringe driver if that is available, or at least a dial flow that you get, okay, so that you have constant rate of the medicine that is going through. It should not be that, it should not be very casually calculated, because up and down can both cause either decreased efficacy or side effects. So it should be monitored carefully. Next slide, please. I think we've covered all these. So next slide, please. This again we've covered. Next slide. Okay, so for managing acute pain crises that come up in your OPD, there are two ways of doing it. You can give either intravenous or subcutaneous. And you would, because you're giving boluses of morphine here, you would generally give an antiemetic beforehand, even if the patient is not opioid naive, with metoclopramide or haloperidol. Dilute the morphine in 10 ml of NS. And generally what is preferred is 1 milligram per minute up to 10 milligrams is the scheduling. So what I mean by that is that you give 1 milligram, that is generally the vial is, the ampule is 10 milligrams of morphine. When you dilute it in 10 ml, so 1 ml would equal to 1 mg of morphine. So you give 1 ml every minute if required till pain control. So the pain control can be in 1 milligram, it can be in 5 milligrams. So it varies from how much the patient requires, right? So maximum of at one time. So every minute wala jo boluses hai, maximum of to 10 times, because 10 mg we are giving. Then you need to wait for at least 5 to 10 minutes. Then again, you can repeat the same process. Okay, just to get an idea if the patient is actually requiring that much medicine or not, because obviously because you're giving intravenous, there is a high chance that the patient might have respiratory depression or can be highly sedated. So that is the general scheduling. IV to subcut is generally twice the amount. So 2 milligrams you'll have to give subcutaneously, but you need to wait every 5 minutes. So 2 milligrams, wait for 5 minutes, because it needs to get absorbed and then have its effect and everything. So 2 milligrams every 5 minutes for till 10 milligrams. Again, wait for 10 minutes and then you can repeat it if required. So this is for managing acute pain crisis with injectable morphine. Next slide, please. Coming to fentanyl. So fentanyl is again a pure mu agonist. It is highly lipophilic. So basically gets concentrated in your fat cells, right? That's why, and it is very fast acting. So it has its effect, the surge intravenous I'm talking about. The intravenous surge would be in like 2 or 3 minutes, and then and it goes off equally fast. So in 15-20 minutes or maximum of half an hour, the effect would have gone off. That's why when you're giving injectable fentanyl, it's usually a continuous continuous infusion, not boluses, right? So what happens is when you're giving fentanyl, it gets stored immediately into your fat cells and it crosses the blood-brain barrier also, but not as well as morphine does. Or morphine in the vascular system is also comparatively more than fentanyl, though fentanyl is 100 times stronger than morphine. Now, the advantages of fentanyl is, firstly, as I said, it is very safe in both hepatic and renal derangement. It is less constipating. It has less nausea, vomiting, and withdrawal symptoms with fentanyl would be comparatively less. And again, it has lesser effects on all the sphincters. So all the, like the gallbladder colic or your urinary bladder colic would be comparatively less with fentanyl. Next slide, please. So generally, for chronic pain, we would give fentanyl patches. It basically provides a very stable and continuous dosage of fentanyl in the bloodstream and thus managing the pain. It can be used as an opioid rotation. It can be used if the patient is requiring a very high dose of oral morphine or any other medications, and morphine is, let's say, not feasible in that patient. It should be used in patients with derangement of liver and kidneys, especially if the creat clearance is less than 40. There are side effects and adverse effects of fentanyl as well. So basically, you need to remember that it is a strong opioid. It is not to be used in acute settings. Patches, I'm talking about fentanyl patches. Patches cannot be used as in an acute setting. In acute setting, injectable works wonders, but not the patches. So post-operative, it will not have its effect for the next 24 to 48 hours. That is the amount of time required for the medicine to get absorbed into the system, right? So there's a lag of 48 hours, maybe sometimes 72 hours as well. Then how to use it, how to store it, how to discard it should be taught to the patient. Signs of overdose and required medical attention should be told to the patient and the relatives. The rate of absorption increases with fever or any vasodilatory effect of any other due to any other reason as well. And also, if there is an abrasion over the area where the patch is applied, that will also increase the rate of absorption. So it should be taught to the patient. Education or the relative education is equally important here. Drug interactions which can potentially increase the levels of fentanyl should also be noted. So any drug which would increase the dose of fentanyl should either be not started, or if has to be started, then the dose of fentanyl should be reduced so that it compensates for that. Next slide, please. So basically, you have the brands that are available with us are either Durogesic, Finrid, or Fentouch. Durogesic is the patented company, like it's the mother company. Usually the efficacy of patches is better, is observed, it's better. The rest of them are also equally effective, but sometimes might require the higher dose of the patch to get the same effect. It is generally applied over any area which has some reservoir of subcutaneous fat. It should not be an hairy area. If hair are present, then they should be clipped with scissors and not shaved, because there's a chance of abrasions over that area. So it should be clipped. And the site of application should be regularly changed. Like, so if you are applying on the, let's say, the right side of your chest, then the next application should be on the left side, or wherever you want to apply it. The only precaution is, as I said, if the patient is having fever, then avoid fentanyl patch. If any abrasions, apply over another area. And it should be changed every 72 hours. So make sure to educate the patient or the relative to write down the date and the time at which it was applied, so that they have an idea when to change it. Yeah. So that is the basic things that the relatives and the patient needs to be educated about. As I said, it takes around 24 to 48 hours to start acting or to have its effect after the first patch that is applied. So if you want to titrate the dose of the patch, it has to be done every 72 hours. That is the only drawback that we have in any transdermal patches, may it be fentanyl or buprenorphine. Next slide, please. The common adverse effects of opioids are basically, you have your initial ones, which are nausea, vomiting, drowsiness, lightheadedness, unsteadiness, or delirious episodes, which still persist after many days of use, is constipation, occasionally nausea, vomiting, and dry mouth. Sometimes it is suspected to have suppression of hypothalamic pituitary axis and immune system. The less common ones are your neurotoxicity, myoclonus, allodynia, opioid-induced hyperalgesia, cognitive failure or delirium, hallucinations, pruritus, and sweating. The rarer ones are your dependence and respiratory depression. So what we are worried about is quite rare. Again, as I said, there should be some, there should either be some risk factors for respiratory depression, or if a very high dose is given, bolus. So otherwise, it's generally very safe to be used. Next slide, please. So as I said, we have constipation, that is gastric stasis. So generally you have fullness, flatulence, hiccups, decreased appetite, nausea. So anything to increase the motility of the gut would work. So metoclopramide also would work. If you want to go for laxative, then your usual more softeners, because of constipation the stools become hard. So softeners plus some motility agents would be the ideal choice of laxative here. So I would generally give either cremafin or dufalac, or even PEG, polyethylene glycol, to soften the stools, and motility agents like bisacodil to help with the motility of the gut. So basically has a good effect, and it does not cause any fissures or injury in the anal region because of the softeners as well. So sedation generally is very for a very small duration, and if it is persistent, or if the patient is sedated for most of the time of the day, then it's better to reduce the amount of morphine or any other opioid that we are giving him. Cognitive effects like agitation, delirium, or hallucination, then antipsychotics like haloperidol or olanzapine can be given in this case. If myoclonic reactions are present, they usually present as twitching or jerking of the limbs. You'll have to start them on benzodiazepines and reduce the dose of the opioid. Vestibular stimulation, basically it will lead to your motion sickness. So cyclizine or promethazine can be given, or any hyoscine can also be used here, but does not have that much of an effect. Next slide, please. Your neurotoxicity, again, you'll have spasms, jerks, allodynia or hyperalgesia. Then you might have to either do opioid rotation or change from one opioid to another to see if the effect is less, or reduce the whole opioid dosage in general, or give benzodiazepines. Pruritus with because of opioids is pretty rare, and there's a whole body itch which is not related to any of the organ dysfunctions. So generally the first line is ondansetron, either oral or injectable, twice or thrice a day according to how the patient is responding. Any dyspnea or bronchoconstriction because of histamine release, then the usual antihistaminic or bronchodilator can be given. Next slide, please. In short about adjuvant analgesics. So what adjuvants we have is your corticosteroids, you have your antidepressant, antiepileptics, NMDA receptor blockers, your muscle relaxants, bisphosphonates, and antiarrhythmics. Next slide, please. So basically for adjuvants are generally for neuropathic pain. So for first line would be your TCAs or gabapentinoids. Second line would be your SSRIs SSRIs or SNRIs. Basically what you do is, if you've given TCA in as a first line, then the second line or the second drug should be something that acts through another channel. So if you have given TCS, then the second choice would be gabapentinoids. If already a combination of gabapentinoids and TCS is going on, then the next choice would be adding something that acts differently from both of them, that is SSRIs. So that is how you up titrate the dosing for a neuropathic agent. Now, next slide, please. So again, your first line for various disorders. You can just go through this. I'm just giving it as a summary. Next slide, please. Strong pains. Yeah. So when they say, next slide, please. I think I'm at the end of, yeah. So can you just go 2-3 slides up where I for the adjuvants, where that slide. One more. Yeah. So as I was talking about NMDA receptor blockers, so the NMDA receptor blockers that we have with us would be your methadone. It is a good mu receptor, like opioid mu receptors plus NMDA action plus SNRI action. So it has 3 ways of having its analgesic effects. I've not discussed it in details in this particular presentation, but what is a major drawback of methadone is it has to be very, very closely monitored. It has a potential for QTC prolongation, so it has its cardiac effects as well. A good analgesic, but has to be titrated and monitored very closely. If available in your area, it can be used very well, and it might sometimes even mitigate the need for any procedural blocks as well. So it's a very good drug, but has to be monitored very, very closely. So the dosing also should be, the prescription should also be only for 1 week each, and ECG has to be repeated every time, at least for a month. And after that, you can maybe call them every 15 minutes, 15 days or 20 days. So it has to be titrated very closely. Another NMDA receptor antagonist that we have is your ketamine. So ketamine can be used orally or injectable. The dosing, again, you'll need a very low dose of ketamine injectable to have its effect on the neuropathic pain. So it is one of the medicine that is used for neuromodulation. If I'm not sure if they've covered the neuromodulation in your syllabus till now. So neuromodulation is basically to it's neuropathic pain crisis, to put it very simply. So one of the drugs that is used is either lignocaine, which is an infusion, or ketamine. These are the two drugs which are used for neuromodulation in general. Ketamine, again, very fast acting, but again, the effect goes off equally fast. Very low dose is required. It can be given, we have tried it in OPD basis, and it works wonders for neuropathic pain crisis especially. So those are the two that I wanted to specifically mention. Smooth muscle relaxants should be it all comes down to assessment of pain basically. So you need to assess the pain very well to know what kind of pain it is. Then you can give the medicines accordingly. Opioids, whether weak or strong, cannot be just a blanket case for all type of pain. If the person is going through or is having muscle spasm and musculoskeletal pain, no opioid will have good effect on it. You will need to add a smooth muscle relaxant or skeletal muscle relaxant in the prescription. So assess the pain well, understand what can be the potential cause for the said pain, whether it is nociceptive or neuropathic or muscular pain, and then give or bone pain, and then prescribe the medicine. So why I mentioned bone pain is that bone pain generally would react best to either steroids or NSAIDs. So they might have to be included in your prescription if the person is having specifically bone pain. Bisphosphonate that are mentioned here are generally for your skeletal lesions, and to prevent, it helps with pain and also helps to reduce the chances of any skeletal related accidents. Yeah. Okay, that's about it. I think we'll go on to questions that we have. It's basically, we had given the dose of 2.5 milligrams of ketamine, 2.5 milligrams of ketamine in 10 ml of NS, and then we had given a slow push, and if required, we had repeated that. Okay, so that was just to kind of break the cycle of the pain crisis, and then we started on oral neuropathic agents. We have given oral ketamine also to patients. So basically the whole vial of ketamine, we mixed it in 1 liter of Maza, and we told them to take, we had calculated the dose according to how much the patient was requiring injectable, and we had asked them, and we calculate how much would be in 1 liter, and then we had given the dose accordingly. Not 2.5 milligrams per kg, 2.5 milligrams of ketamine. That's it, not per kg. 2.5 milligrams bolus in 10 ml of NS, very slow push. You generally don't require close monitoring with ketamine. As I said, it's very fast acting. So it goes, does its job, and it just leaves. So you can give simultaneously, you can give them opioids or some other analgesics to continue to have that continued analgesic effect, but it works wonders. Anything else? It depends on how much IV ketamine was required. Then you calculate the dose of oral that would be required by the patient. Preferred analgesics would be for liver particularly, you mean to say, or for in opioids, I would prefer fentanyl or buprenorphine, not any other in liver diseases or in kidney diseases. For if it's not opioid, then I would avoid paracetamol, or I would limit the dose of paracetamol to 2 grams in liver disorders, because higher dose can cause further damage. And renal, I would avoid NSAIDs, or give something that is it does not have that much of an effect on the renal function. So those are the only things that I would avoid. Shall we proceed to the case presentation?
Thank you, ma'am. Thank you for the presentation. So I think we have an initial talk about the case presentation. So we'll just simply go through the case presentation and forward to the discussion. Dr. Juhail.
Okay.
Any queries you have existing? I know definitely this is a big topic and you'll definitely have queries. Please send in to the WhatsApp group or we'll definitely get the answers to you. Dr. Jola?
Okay, thank you. I'm back. Actually, okay. Can I start from the beginning?
Yes, so that our honored faculty can also get to know about the case. So we'll have a quick brush through the details.
Okay, thank you. Okay, today's case presentation is about a 24 years old female patient who was diagnosed with a left breast cancer, angiosarcoma with a bone and lung metastasis. Next slide. Upon presentation, she was having worsening of shortness of breath of 7 days duration, cough, severe pain over the left leg, as well as loss of appetite. Next slide, please. She was initially diagnosed with left breast sarcoma 2 years back. After presenting with a left breast swelling of 3 months duration, she got admitted and a mastectomy, modified radical mastectomy was done, and she was eventually discharged with a short appointment. Later, she was started on chemotherapy, which she took about 6 cycles of second-line chemotherapy, and she disappeared for 2 months, where she tried holy water, but with no improvement. Yeah. At that time, she was taking morphine 30 milligram every 6 hours, as well as bisacodile. Upon the current presentation, she was having severe 8 out of 10 continuous dull pain over the left thigh of 1 week's duration. She was also having moderate 5 out of 10 of intermittent stabbing pelvic chest pain, shortness of breath, cough, and loss of appetite with loss of weight. Upon examination, on general appearance, she was on respiratory distress, respiratory rate was 32 breaths per minute, pulse rate she was tachycardic 120 beats per minute, air BP was 118/82, and her temperature was 98.2 degrees Fahrenheit. On oxygen saturation, it was about 82% on atmospheric air. On systemic evaluation, on respiratory system, there was dullness and decreased air entry over left one side of posterior lung field. On musculoskeletal system, there was tenderness over proximal femur area, and there was also muscle atrophy of bilateral proximal and lower extremities. Otherwise, on other systems, there were no pertinent findings. Next slide, please. For this, she was investigated with CBC. WBC was 4.1,000, neutrophil of 60%, hemoglobin was 8.5 grams per deciliter. Her platelet was 320,000, serum creatinine was 1.02, and serum electrolyte was relatively in normal range, like sodium and calcium are borderline normal. And chest CT, left pleural based lung mass, and hilar lymphadenopathy and left pleural effusion, most likely lung metastasis of breast CA. The impression of the chest CT. The patient was put on intranasal oxygen at 5 liters per minute, which was eventually raised to 5 liters per minute. And she was started on morphine 4 milligram every 4 hours and bisacodile 5 milligram per day. She was also put on maintenance fluid as well as other supportive care. Gradually, she maintained oxygen saturation, but she still continues to complain, having pain, pelvic chest pain as well as leg pain. Upon progressive assessment, her pain score for the leg pain was 7 out of 10. Initially, it was 8 out of 10. and that of chest pain was no improvement infantily. She has taken first line, second line chemotherapy and was booked for third line chemotherapy before her current presentation. Next slide, please. From psychosocial aspect, she's a 24-year-old unmarried woman living with her parents. She has 3 siblings, one of whom is a medical officer who is currently supporting her, as well as the family. She's a devout Orthodox Christian who used to go to church. She feels sad that she cannot visit the church as before. She has a low mood. She feels tired and hopeless. She's not very communicative about her illness. Her brother, who is taking care of her financially, feels frustrated, uncertain whether to continue the booked chemotherapy, and he keeps asking, her pain and the condition are not improving. What do you think is the best you guys can do to improve her current condition? Next slide, please. The current medications, she's on intranasal oxygen, morphine 4 milligram every 4 hours, bisacodyl 5 milligram daily, maintenance fluid. She was already booked for second line chemotherapy. Next slide, please. The main concern of this patient is, the main concern from this today's presentation is leg pain, other physical symptoms like cough, shortness of breath, loss of appetite, depressed mood of the patient, and the stress of the family, specifically one related to her brother who's taking care of her. Next slide, please. To summarize, this is a 24-year-old unmarried woman having left breast angiosarcoma. It's bone and lung metastasis, presented with a complaint of worsening of shortness of breath and left thigh pain of 1 week's duration. She has associated cough, pleuritic chest pain, and loss of appetite. She has taken 6 cycles of second-line chemotherapy and disappeared for 2 months from the follow-up. She feels depressed. Her family is bothered that chemotherapy and other interventions are not bringing relief to her suffering. Next slide, please. Discussion points for this case are, there are 2 main discussion points. One is role of opioid in management of the cancer pain. As mentioned, the patient was, for this specific case, she was initially on pure 30 milligram pure morphine, which she was taking every 6 hours before current presentation. Upon admission, the morphine pure dose was changed to switched to IV, and she was put on morphine 4 milligram every 4 hours. And still she was complaining pain despite being put on morphine 4 milligram every 4 hours, and she was having 2 breakthrough pain within 24 hours. So one of the question is for discussion is, how do I adjust her morphine dose to control her current physical symptoms? And the second point is, if her pain is not controlled with the tolerated dose of morphine, what alternative opioid can you give for this specific patient? Other points for discussion is managing psychosocial issues. The patient as well as the family go psychosocial issues as mentioned on presentation. And do the psychosocial problems, specifically that of the patient, relate to the difficulty in managing her pain? If so, how do you address the psychosocial issues of the patient and the family? Thank you for attentively listening. You can forward your comments, suggestions, or questions.
Thank you, Doctor. So after the case session, these are the questions we have to discuss. How do we adjust a morphine dose to control a pain symptoms? So what is the team's opinion on that?
Can I just ask you clarifying questions?
Yes, please.
Okay. So Dr. Juled, I'm sorry if I'm mispronouncing your name. Can you please describe the pain for me? How so it's basically lower limb pain. But can you just describe it in the sense of if it's throbbing, if it's kind of radiating somewhere or pricking sort? Can you just describe it in how the patient would have described it?
Sure, thank you. I can describe. The patient described a pain was upon evaluation. The left leg pain was severe, dull pain that does radiate to other part of her body, but she claims to have some sort of relief when she takes other other OTC drugs in addition to the usual morphine dose she's currently taking, and her pain gets worsened with movement.
Okay. So, what other drugs apart from morphine that she said helped with the pain?
Apart from morphine, she claims that she was not consistently taking specific OTC, but she said that at different times she was taking additional acetaminophen, additional NSAIDs like diclofenac, 50 milligram per dose.
So from the way you're describing it, it feels that it is the bone involvement that is causing a lot of pain for the patient, right? And typically she's having relief with either paracetamol, acetaminophen, or any of the NSAIDs that she's taking. So do you feel that adding a regular NSAID in the regime would be beneficial, or adding, let's say, if not NSAID, adding adjuvant corticosteroid would help in this situation? Anyone in the group can answer. Yes, someone said that it's bone pain, we will require steroids. Okay, steroids or NSAIDs. Okay, so what would be the preferred? Let's if we are giving steroids, then let's say it's Dexa. And anyway, she's planned for some a second line of chemotherapy. So many of the times it is included in the regime of chemotherapy. So
Ma'am,
long term.
your voice is breaking up, I think, again.
Hello, can you hear me now?
Yes, ma'am.
Yeah. Okay. So sometimes Dexa, like if it is bone pain particularly, we cannot give steroids for a very long time. So we might have to switch on to NSAIDs at a given time if required. So what would be the ideal choice for NSAIDs to be used here?
Okay. Can I add some point on?
Yes, please.
Okay. Actually, as I previously mentioned, she was on NSAID. She was taking OTC NSAIDs like diclofenac, as well as acetaminophen, but that didn't get her maintain her pain. Still, she was having, despite early improvement with this, it get worse. Her pain got worse, so she visited the hospital later.
Okay, no, but in general, I'm not talking about in this particular patient. Because bone pain generally respond well to either steroids or your NSAIDs or bisphosphonates or denosumab, whichever is given here. So if suppose in this case only, if she was responding to diclofenac, let's say for 6 hours, I'm just arbitrarily assigning how much she was getting relief. But if she was getting relief for, let's say, 6 hours, so would you say that giving diclofenac 6 hourly would be beneficial alongside morphine, or would you want to do something else?
I think one of the options is we can try with NSAIDs, or I can go for other adjuvants like gabapentin. Usually in bone pain in patients having bone metastasis, the evidence is that adjuvants like gabapentins might help improve the pain.
Okay. So which would be, if we are talking about NSAIDs, we'll come to each of them separately. So if we are talking about NSAIDs, which would be preferred for a long-term use? Anyone, not just Juliet. Anyone. One said ketorolac or naproxen or ibuprofen. Okay. Anything else? Not preferred long term. Yeah. So naproxen, ibuprofen are comparatively. Tapentadol is not. It's an opioid. So COX-2 inhibitors.
I think COX-2 selective inhibitors.
Yeah, selective COX-2 inhibitors would be preferred for a long-term use. So either eterocoxib if that's available, or celecoxib. Celecoxib has the disadvantage of being a bit on the expensive side, but if available, eterocoxib or celecoxib. Now ketorolac, ketorolacs or the non-selective COX or or the COX-1 have a lot of side effects related to gastritis or nausea, and those. So those are more in non-selective. And naproxen generally, I mean, it does have a good effect in pain, but if it's very severe, then it does not have that much of an effect as diclofenac or others would have. So, yeah. Okay. If it is, let's say we are talking about gabapentinoids or some neuropathic agents, which would we prefer first for bone pain? And what would be the mechanism of action in this case? Anyone? Huh? I'm not giving it specifically to someone. Anyone can answer. Pre-GABA. Okay. So coming to gabapentinoids, what is the mechanism of gabapentinoids in bone metastasis, bone pain? Yes, it does have a high chance of cardiotoxicity, but we are weighing in the benefits and so what happens is generally if we are giving it alongside some disease modifying agent, then you would hope that the lesion in the bone reduces and subsequently the pain reduces, so you won't have to use it for a very long time. But having said that, I have given celecoxib and eterocoxib for patients for a year or so and have not had any cardiac events. So I guess it has to be monitored and titrated accordingly. So pre-GABA basically, or any neuropathic agents would basically help in reducing the not the sensitivity per se, but what would it do is mitigate the nerve endings which are getting affected because of the bone lesion, right? So surrounding ones, those are the main actions. It does have an effect. I would not say that it does not have an effect, but effect compared to either steroids or NSAIDs would be way less with any of the neuropathic agents. So it can be used where there is nothing available, or you have tried everything, and then maybe you can add in, or you can add in simultaneously because it will take care of the neuropathic pain as well. But again, needs to be monitored, titrated according to the need of the patient. Okay. And don't forget to start the patient on regular bisphosphonates or denosumab, whichever is available or whichever is preferred to be given in your institute, because it helps a lot with the pain, with the skeletal adverse events like fractures or anything, and also keeps in check your hypercalcemia if if at all it is going to develop. So please start on a regular regime. So we monthly injectable zoledronic acid or weekly your alendronate, whichever is preferred. Local infiltration of lignocaine. So basically, you're talking about your interventional analgesics. They can be given, but the effect won't last for long. Basically, the receptor at which it acts is different. So I'm not very sure of how it will act. Local injection of steroids may help. That can be tried. But again, if it's like mid-shaft femur, then you cannot give, you cannot localize the area where you want to give either lignocaine or NSAID, because it's not into like a joint cavity or anything like that, right? So again, you'll have to, for local infiltration, you'll have to maybe consult a pain specialist, like interventional pain specialist. Yes, so paracetamol, will work in neuropathic pain, but at a higher dose. So 1 gram infusion may help with neuropathic pain. Again, it differs from patient to patient. Some might respond, some might not respond, because the mechanism of action of PCM is, they say that it has a component in gabapentinoid system as well. So that would work via that for neuropathic pain. But again, the efficacy of that, I'm really not sure.
Shall we move for the next question?
Yes.
If a pain is not controlled with the tolerated dose of morphine, what alternate opioids can you use?
So you would want to go on a higher or a stronger than morphine opioid. So that gives you, that leaves you with the option of either fentanyl, buprenorphine, or methadone. So whichever is more comfortable to be used should be used. So fentanyl is generally very easy to use, and you can start off with an infusion, get a baseline dose of how much the patient is requiring. Transdermal to intravenous dosing is almost same. So you can, adjust it to that much amount of patch. So if the patient is requiring 10 micrograms infusion throughout the day, or per hour rather, not throughout the day. So if the infusion rate is 10 micrograms per hour infusion, then you switch on to 12 micrograms of fentanyl patch. So it's same. It does not have a lot of conversion rate. So fentanyl is, I would prefer fentanyl. Buprenorphine is another option. The only thing is that not all kind of pain will respond to buprenorphine. So you need to be sure that the pain will have effect, or rather pain will be reduced with buprenorphine before starting him or her on patch, because it's expensive if nothing else. And methadone, as I said, you need to titrate it and monitor it very, very, very strictly. So if it is available and you have the what would I say? If you have the manpower to monitor it very well, then methadone would be the best choice. Denosumab is expensive. Yes, it is expensive. Yeah.
Regarding the psychosocial problems, I think the team has come up with a large number of very good almost all psychosocial issues have been shown up, like
Yes.
The depression, anxiety, feeling of loneliness, doubtful about our future.
She has a spiritual issues as well, right? I mean, she was a devout Christian who would go to church every week, and she's unable to go. So she has that spiritual aspect of kind of increasing all her symptoms and distress as well. So what would be an ideal way of managing these psychosocial spiritual issues? And how does it relate to pain? What would it do to the pain?
Usually, for a patient who is having such kind of cancer pain, usually we have to, if the pain is uncontrolled, usually one of the factors we have to look for is if the patient is having psychosocial as well as spiritual issues that are not well assessed and well managed. So in our case, we have a patient having psychosocial problem as well as spiritual problem. So since he's not too much communicative, we have to thoroughly assess the spiritual issues as well as psychosocial issues, and we have to address it. Unless otherwise, it makes it difficult for the pain to be managed. It might with only pharmacological interventions.
So it leads to increased perception of pain. So if all the aspects are not managed properly, your psychological, your social, and your spiritual, along with your physical, if it's not managed simultaneously and well, it leads to increased perception of pain, or it can even lead to catastrophizing effect of, or catastrophizing pain. So basically what catastrophizing means is that whatever you do, how much ever dose of medication you do, pain is the same. Or it's like, abhi kuch nahi ho sakta, you know, nothing is working, I'm going to die. They just basically kind of escalate very fast. So that is called catastrophizing, or catastrophizing any symptom. It does not have to be only pain. It can be with any symptom that the patient is going through. So as you correctly said, you need to manage all these well. Now let's break it down. Let's break it into psychological issues, social issues, and your spiritual issues. So let's start with psychological issues. So what is she suffering through? She's suffering through anxiety. She's suffering through depression. She has social isolation and sort of stigmatization of all because of breast cancer, not married, and everything else. So all these things. So what would be an appropriate way to approach it? One is counseling. Okay. Will it be possible to switch on the charger if possible? Otherwise, not sure how to do it. Okay, one is counseling. Anything else you can think of? Support group therapy. Okay, excellent. Anything else? Okay, so maybe you'll start on with some medications, TCAs or SSRIs or anything. So pharmacotherapy would actually take a long time to start acting, to have its full effect on anxiety. Anxiety, not so much, but for depression, it takes around 3 to 4 weeks to have its complete effect and start having whatever improvement you need to see. So pharmacotherapy would be your last one. So you would prefer non-pharmacological, motivational trainers, psychologist counseling or volunteer counseling, or as someone mentioned, group therapy. CBT can also be tried for cognitive behavioral changes. Okay, anything else? Do you feel that the psychological issues are being aggravated because of the social issues and because of the spiritual issues? Would addressing those help her? Allowing her to go to the church. Okay, that's an excellent point. I was actually waiting for someone to say it. So if it is, one is allowing her to go to the church, like she visits the church in person and attends the sermon according to her regular schedule. If that is not possible, if it is not possible for her to move around, then what is another way of managing that, or getting her to feel yes, requesting the priest to
Getting a religious leader.
Sorry?
Actually, we can get a father or a priest
to do
visit
a home
her and to give her counseling.
That's possible, you know. So, and the interesting thing is that sometimes talking with the father or the priest can actually help her overcome her psychological issues as well. It can it will help bring down the anxiety and improve her mood. So, just because she would have a lot of questions, and she would be obviously scared because of the disease, because of all the things that she's going through, because of the severe pain, etc. Like, so, having a good spiritual guide, priest or father, or whoever, have a word with her would help you manage the psychological issues well. So maybe you can sit down with the priest and with the patient and have a good talk about how to go about things and all. So that can help manage the psychological and the spiritual issues very well. And for the social issues, you can maybe ask her friends and families to visit her, in the sense, talk about things that are very important to her, apart from the disease. So let's the basic agenda of any social interaction is to make her or help her take the mind off the disease, right? So that is how you would help with the social issues or the psychological issues as well. So you ask the friends and families to come down, visit her, talk about everything else apart from the disease or what she's going through. So that would help her as well. But again, that depends on what kind of a personality the patient herself is, and how she responds to these social interactions as well. Any other way of alleviating her social issues that you can think of?
Other way you can think of it, there are other organizations that support people suffering from like limiting illnesses. We can link her for such kind of services.
Yes, that can also be done. Or any simple distraction techniques also at home. Simple distraction techniques like listening to music, watching television, reading if she likes reading, knitting if she likes knitting, or whatever activity she enjoys doing would help take her mind off things and help with anxiety, depression as well. So that is another, yeah. Counsel of family members, counsel and maybe educate them about burnout of caregivers as well, because burnout, especially with relatives of cancer patients, becomes very high and sometimes might even lead to neglect of the patient also. Not always, and I'm not saying that it can be prevented 100% of the time, but maybe educating them about burnout so that they have their own personal time, so that they can take better care of the patient. Hello, can you hear me?
Yes,
Yeah,
ma'am.
ma'am. Now we can.
Yeah.
Yes,
End of life care, maybe we'll have to take it up very gently, in the sense that since she's just planned for second line of therapy, maybe see how she is responding to the therapy and then go ahead with it. One way of doing it is being very frank with her and saying that she is having your disease has progressed and we are giving you medications which are different from the previous cycle, and we'll see how it goes. So you give her the bad news and simultaneously you're giving her hope that you're trying out new medicines which should help her. But you're not giving false hope in the sense that everything will be all right. So you need to balance both of them as well. End of life would be when end of life, what do you exactly want to, what do you want to say? Do you want to say what she wants to be done or not done during her end of life, or anything else, like imminently dying wala phase? Because the patient can take it the other way also. The patient can just take it that, oh, I'm going to die, nothing is going to work, and she might just further spiral down into anxiety, depression symptoms. So you need to be very careful when you're discussing end of life.
Hello, ma'am. Yeah, that's exactly why I asked that if we should tell her anything about such.
what I would start off with is saying that it is a metastatic disease now, but we are trying out second line of therapy in this particular case I'm talking about. Yeah. So I'm trying out second line of therapy and we'll see how it goes. In case she's not improving on this, then I would say, you know what, it's not looking good. The disease does not seem to be responding to whatever medications we are giving, and it's having a lot of side effects, and we might have to stop the medications for the disease per se, but we will continue with the supportive management for pain, for nausea, whatever she's having, and then let's see how it goes. But I don't feel it's going in the right direction for us, right? So that is one way of doing it. If she's improving on the thing, so the good news is that we are seeing improvement with your overall health. But since it is a metastatic disease, the therapy is palliative in nature, because that's generally how it is. So we might see a very turbulent course of disease with sometimes increased symptom burden, sometimes with no symptoms at all. So, you know, you kind of have to counsel according to how she's responding to the therapy. At this particular moment, I would not want to tell her about end of life, because that takes away the hope about the further management.
Thank you, ma'am.
Financial support by other family members. Now, so it depends on family to family again. We cannot force anyone to financially support other members. There are quite a lot of NGOs or funders who give financial aids for cancer patients. So maybe that is a good way of, or you know, to get in touch with those NGOs via social workers if it's available in your area.
Thank you. If I may ask, I have a question.
Yeah, please.
My question is generally related to acute pain management in a patient having cancer. What is the role of patient-controlled analgesia, PCA,
so in
management of acute pain?
Acute pain, you would have to give boluses, right? So maybe once you've tied over the acute pain, you can switch the patient onto a regular infusion or a continuous infusion of whichever medication you're giving, and give patient controlled analgesia simultaneously on the continuous infusion. Because I'm assuming you're talking about CAD pump with PCA, right? Or are you talking about anything else?
Yeah, I'm talking the same.
Yeah. So I would first tide over the acute pain crisis with boluses of, let's say, fentanyl. I would titrate how much is the dose requirement with boluses, and then put on the same dose or on a continuous infusion, and then give PCAs simultaneously with the infusion. So directly putting the patient with acute pain on PCA would not have that much of an effect, because PCAs are generally timed, right? So you can give one bolus every, let's say, 10 minutes or 20 minutes or 30 minutes. You cannot give, suppose the pain is not relieved with whatever dose in, let's say, 2 minutes, the patient will want to give it again, but it does not go. So the patient continues to be in pain for that much time, right? So first give boluses, titrate the dose, put the patient on infusion, and then start PCA.
Okay, thank you.
So end of life discussion should be done according to the personality of the patient. If the patient is the one who would want the knowledge about whatever is happening to her upfront, and that knowledge will help her manage everything well, then she should know. If having such knowledge would further increase her distress, then it's better to discuss it just with the family. So you need to kind of adjust that way. Yeah, government hospitals, the socioeconomic strata is totally different. So they usually come from a low socioeconomic strata. So yeah, especially with cancer patients, what happens is it's actually financially draining. Despite so many government schemes and everything, it's very financially draining. So the usually comfort care or no further treatment generally stems from lack of funds for the treatment. So yeah, I completely agree with you. There's the suffering is mostly because of the lack of economic support. Not everywhere. I'm sorry to say, not every government hospital has a lot of funds for cancer patients. It's still very expensive, especially if you require medications which are targeted, then those are either not covered with the government schemes or are not available in the government hospital. So they need to buy it from outside. Yeah.
I had a doubt, ma'am, regarding morphine. Should it be given fourth hourly? Like, can it be released?
Dr. Divya, you're not audible. Can you repeat the question, please?
The morphine, regular morphine, shouldn't it be given fourth hourly? Only BD or thrice daily, will it be enough? Not the sustained release. The normal morphine, fourth hourly, is it not required? Like ma'am was telling, it can be given BD or thrice daily also, the regular morphine.
It depends on patient to patient. It differs from patient to patient, because I still have few patients who are taking instant release morphine twice a day and they are comfortable with it. And certain patients, they don't have the effect does not even last for 4 hours. They have to repeat the dosing every 3 hours or 2 hours also. So it depends from patient to patient. You'll have to titrate it according to their physiology, basically.
Okay. So,
That clears your doubt.
thank you, ma'am, for the wonderful session. Thank you, everyone. That was a very interactive session. Everyone was participating well. I know you might have more queries to end. Please send in the queries to the group and we'll get it cleared and informed to you back. Shall we wind up the session for the day, ma'am?
Yes, please.
Thank you, everyone. Have a good day and have a good night. See you all for the next session. Thank you, ma'am, once again for the wonderful session.
Thank you. And apologies for joining in late.
No, it's okay. We had a very good session after that. Yeah. Thank you, ma'am.